So far, in Chapter 1, we have talked about the anatomy and physiology of the heart, the blood flow, the parts of the heart. Chapter 2, we talked about the conduction system of the heart. How do we get that electricity? How is the heart autonomic and mechanical? Chapter 3, we talked about lead placement and electrodes. How do we read the heart's electrical conduction by the electrodes and by the lead placement on the patient? So now Chapter 4, we're going to talk about the mechanical, the technical aspects of the EKG. So don't get too excited. We're not learning a rhythm yet. Chapter 5, you're going to start. In Chapter 6, you're going to learn how to interpret a rhythm. And then that's next week. And then starting with Chapter 7 is when you're really going to start learning rhythms. But Chapter 4, we're going to focus more on artifacts. We talked about it in Chapter 3, how an artifact is something that is not real, is a false reading. And we're going to talk about the machine now that you know how to place the electrodes and the leads. So electrically speaking, the heart is a transmitter and the EKG is the machine, is the receiver. The electrical impulse, remember, an electrical impulse is that spark, the fire at the end of that firework, that shock that you get when you plug something into the wall. That's your electrical impulse. That's depolarization, when your sodium and potassium ions pass each other and we get a charge. Your conduction system. It is generated through the heart, course throughout the body. Electrodes pick up these impulses. So that's the stickies that we talked about in last chapter. We're going to place on your patient. They're going to pick up these impulses, this spark, this electricity, this conduction, and they're going to send them through the lead wire to a cable into the machine. So the lead is what we're going to connect to the electrode, and through the lead wire it is connected to the machine. So electrically speaking, the heart is a transmitter and the EKG is the receiver. It is receiving the current from the transmitter. The amplifier turns up the signal, and then we have what's called the digital converter, which converts the analog signal to digital. Your limb leads are your hands or your wrist, not your hands, and your ankles. These are your limb leads. This is your bipolar and augmented leads. And then remember, we talked about your chest leads, which was V1 through V6. And remember, V1 is on the right side, V2 through V6 is on the left side, and V1 and V2 are on your fourth intercostal space, whereas V5 through V6 is on your fifth intercostal space. All right, so E is going to mean your electrode. So they're talking about right here, this little bitty spot right here. That's that electrode that's sticky. And L is going to be your wire. So notice the wire is going to connect to the electrode that's sticky, and it's also going to connect to a transmitter right here. And then of course your machine is your receiver, and then your machine has to be connected to that transmitter, is known as your cable. Notice in the image we have a man attached to the EKG machine. He is in what's called supine position, meaning he is laying on his back, his spine, and he is in a resting position. He's not jumping up and down. He's not on a treadmill. He's not doing his normal activities through the day on a monitor. He is having a resting EKG done. And notice your lead placement, your transmitter, and your electrode. It's hard to see your transmitter, but it looks like your transmitter is up here. And then here's the machine that in the cable that is connected to that transmitter. And then notice all your leads here going up to the transmitter, and then your electrodes is where it is going to be attached to the body. And these wires, you can imagine, they get tangled a lot. In EKG2, we are going to do clinical in the classroom. You're going to make appointments with me. You'll notice it's TBA on your schedule. And you're going to make an appointment and you're going to come see me maybe 2, 3, 4 times, a couple of hours at a time. And you're going to do EKGs on each other in class. And you'll notice that these lines tend to get tangled up very easily. So if you look right here, there's actually a divider that we can use to kind of hold the lines together, but in all honesty, it's still going to get tangled. And then here, of course, don't forget there's your limb lead. Notice it's closer to his elbow than it is his wrist over here. So with that being said, if you have a patient, let's say, who doesn't have, their arm was amputated, their leg was amputated, we can even take that lead and that electrode and move it up here instead. Okay? All right, so your machine, let's talk a little bit about that. First of all, your machine is going to be set at a speed. It's known as its chart speed, and it regulates the speed of how fast that EKG is printed out. The normal speed is 25 mm per second. The gain is going to regulate the amplitude. Remember, amplitude is measuring going the height of the QRS, measuring vertical. It regulates the amplitude of the EKG waves and complexes. The default gain setting is at 10 millimeters, 10 millivolts. It is critical to check the increase in the gain setting if the patient appears to be in a flat line rhythm. So your patient could be talking to you, but their EKG is reading a flat line. Is your patient in cardiac arrest? No, check your gain, check your settings. It should be set at 2, chart speed should be set at 25. The frequency response filters out extraneous noise and artifact. So think about it. This happened this week and I was in Walmart and everybody's phones were going off for the weather alert, right? I can imagine it did it this morning as well. Today is Wednesday. And the rain was horrible this morning, so I can imagine everybody's phones were going off at the same time for that flood warning in New Orleans saying to stay off the streets. Imagine that, all that electrical signals going to everybody's phone at the same time. That's a lot of noise, right? So our frequency response is going to filter out any extraneous noise and artifact. But sometimes, not just talking about our cell phones, they can be other machines in the room that the patient is on, especially ICU. And imagine all the electricity and electrical currents going inside the room. That is a lot of extraneous noise. So sometimes we would have to get assistance in trying to get an accurate EKG rhythm because all that extraneous noise can cause an artifact. So we're talking about electricity, right? We talked about a whole bunch of dangerous situations, right? Lighting a firework to get that spark and watching it igniting and travel, just like the conduction system, the cells travel through your heart, it travels to that wick and shoots off the firework. Or you can touch the plug and get an electrical shock. So if we're putting a machine that's plugged into the wall and attaching it to a patient, could we shock them? We most definitely can. So we have to be very careful and consider our surroundings and what is going on, especially when it comes to shocking our patient and the artifacts from too much noise, the frequency. So macro shock is a high voltage shock resulting from inadequate grounding. So remember when we talked about your positive poles and your negative poles and how your right leg is your ground pole. If we don't have that ground pole, that electricity, it's just going to keep on running through your body. So the macro shock, we can cause a high voltage shock resulting from an inadequate ground. This could be caused by a frayed wire, broken wire, or cords, electrical outlet damage, or other causes. 110 volts of electricity can travel to the patient, resulting in burns, neurologic damage, fatal heart rhythm disturbances. That is the last thing that we want to do with our patients. We know if a patient is getting EKG done, there is something going on with their heart. So the last thing we want to do is shock them and injure them with a burn, neurologic damage, or a fatal heart rhythm. Microshock is going to be a smaller shock that travels up a conduit into the heart, such as a pacemaker or another device. Still dangerous and can be caused by frayed grounding wire or other causes. Your precaution is to check for frayed wires or components before doing an EKG. When I think of a frayed wire, think of your cell phones. Eventually that cell phone charger, it's going to become frayed. You're going to see the lining wear off and you're going to see the wires. That would be like a frayed wire. Or if you have animals and the dogs chew through your phone charging wire and it's frayed and it's got like little pieces sticking out. That would be an example of a frayed wire. So you have macro, which means high voltage shock, and micro, which means small voltage shock. Macro, can we get an injury? Yes. We can burn, cause neurologic damage, cause a heart rhythm to become an arrhythmia. Microshock, which is your small shock, could shock the patient if they have a pacemaker or also a frayed wire. So again, we talked about artifacts in chapter 3. In chapter 2, and a little bit in chapter 3 we talked about it, but an artifact is an unwanted jitter or interference on that EKG tracings. And we can have 4 different kinds of artifacts, okay? So the 4 kinds, the first 2 are your somatic tremors and your baseline sway. These are very similar to their definition, so they're not too hard to learn. Somatic tremors is a jittery pattern caused by the patient's tremor or by shaking wires. Okay, baseline sway is when the baseline moves up and down on the EKG paper. It can be caused by breathing pattern or by lotion or sweat on the skin interfering with the signal. So for example, a lot of women have lotion on, and if you put a sticker on somebody who is well lotioned, that sticker is not going to stick. It's going to slide away slowly, right? So when it slides away, it's going to cause our EKG rhythm to have a baseline sway. And a somatic tremor is somebody who, let's say they have goosebumps. It's cold in the hospital and they're shivering. This can cause a somatic tremor, which gives us a jittery pattern. So if you look at your somatic tremor, remember, what does an EKG look like? We talked about this in chapter 2. A normal EKG, we're going to have a P, Q, R, S, and a T wave, a little bit of space, and then it's going to do it again. P, Q, R, S, and a T wave. That's really poorly done. I'm missing my segment. I can't do it. I gotta erase. No. Let's try this again. Okay. P wave, QRS, and a T. That's heartbeat 1, P wave, QRS, and a T. Heartbeat 2, P wave, and so forth. QRS and a T. Okay? So, if you look at this rhythm for somatic tremor, what do you see? Would you say that is jittery? And in this case, my patient is shivering, they have goosebumps. I am going to have a somatic tremor. All right, here's your baseline. So remember, in chapter 2, we talked about the difference between your segment and your baseline. And if I am a flat line in between my P and my QRS, that is the PR segment. And if I'm the flat line in between my QRS and my T wave, that is my ST segment. So in this case, can you tell, here's a baseline here. Oh, let me get a different color. Here's a baseline here. And then look at my baseline here. And then look at it here, here, and I'm looking in between my R to R intervals, because that's where I should see my baseline. So if I look at my baselines, would you say it's kind of swaying? We started down here and then we went up here. Baseline sway. So imagine the lotion, or somebody who is sweating, or even that maybe they're a heavy breather, and every time they breathe their chest goes up a lot. That's causing the electrode on the skin to move, which gives us the artifact of a baseline sway. Alright, so the remaining two kinds of artifacts we have is your 60-second interference and your broken record. Your 60-second interference results in a thick-looking pattern on paper. It is caused by too many electrical devices. So that's that frequency, that noise that can be in the room. A modern EKG machine rarely displays this interference. Broken record is caused by a frayed wire or frayed or fractured wire, or by loose electrodes patch on the cable. Never do an EKG with one of these artifacts. Now, when you get to EKG 2 and we start doing these in class with each other, the major artifact that you're going to notice is your broken record, because it's very hard to get, we don't have the best electrodes to practice with. So the electrodes don't seem, the stickers, they don't seem to stay on. So you'll find that one of the leads will give us that broken record recording because it simply had come unattached. Alright, here's your 60 cycle interference. You'll notice how thick and dark my baseline becomes. And here's your broken record. Now on our EKG machine, the broken record is going to look more like this. And that's because the electrode has come unattached. Alright, so if we have an artifact, what do? How do we troubleshoot? We're going to involve determining and alleviating the cause of the artifact and recording errors. Find the common limb of the affected leads, direct corrective efforts there. May involve replacing electrode patches or reattaching loose or detached wires. If an artifact is on a monitor in the hospital, you can change the lead selector switch to monitor the rhythm in another clearer lead. So this is actually kind of fun to do. So on the following EKGs, we're going to state in which leads the artifacts is found and necessary for corrective action. Okay, so let's practice and troubleshoot. We're going to see what leads look normal and which ones look like there may be an artifact. And then from there, we're going to troubleshoot and decide which electrode or lead needs to be looked at on the patient or replaced or checked for a frayed wire for artifact. So you'll notice our normal EKG, and it's really bad at using this drawing, but our normal EKG, we should have a really clean P, Q, R, S, and T rhythm. So if we look at this practice problem, we can see that AVR, lead 2, and AVF, I don't know what happened, and AVF have what looks like a normal rhythm. But then we find that in lead 1, AVL, and lead 3, it looks like we might have artifact. Lead AVL looks like it could be a baseline artifact. And then lead 1 and lead 3 looks like it could be somatic, somebody who has goosebumps or is shaken. So what do? How do we fix the problem when we get an EKG rhythm like this? We're going to go back to our hand motions. Lead 1 is right arm to left arm. Lead 3 is left arm to left leg, and AVL is your left arm. So out of those three leads, what electrode is the common electrode? Again, lead 1, right arm to left arm. Lead 3, left arm to left leg. AVL is my left arm. So if you haven't figured it out yet, the lead that is the problem is my left arm. Number 2, again, who looks normal? Lead 1, AVR, and AVL. Who does not look normal? Lead 2, lead 3, AVF. How do we troubleshoot and figure out what's the problem? And also, what kind of artifact do we have? The artifact we have here is a broken record, which means I could have an electrode that is missing or a frayed wire. Now, what lead or what electrode might we be having this artifact? Lead 2 is going to be my right arm to my left leg. Lead 3, left arm to left leg. AVF is my left leg. So who is the common lead that needs to be checked? AVF, my left leg. All right, I'm going to let you do the rest on your, well, do the third one on your own. Moving on to the artifacts. So artifacts can mimic a rhythm. So there are artifacts that can look a lot like a real heart rhythm. Okay, so emergency teams may be summoned to deal with life-threatening rhythms, but later discover that there may be an artifact. So this could be that patient who you are talking to, and their EKG rhythm, the monitor, is showing a flat line, but yet they're talking to you. And you know, if a patient has a flat line, then they're more than likely having no pulse and cardiac arrest. But if they're talking to you and there is a flat line, is this an artifact or is this life-threatening? So do not always believe what you see on that rhythm strip. And you always want to check your patient. This is going to come back to get you an EKG too. The answer is always check your patient. So artifact masquerading as rhythms. The artifact masquerading as a systole is your flat line. So if you don't know this already, a flat line is known as a systole or a systole, however you choose to interpret it. It is caused by a loose monitor patch or a wire. Here you see a perfect flat line. You notice I can't even draw a perfect flat line. So if there is a perfect flat line, do you really think this patient is flat lined, or is it an artifact? It indeed is an artifact. So a true asystole on the next slide is a patient who has no pulse and is not breathing. It looks similar to the previous shot. But notice we have more of a wavy line. This is a true flat line, a true asystole. All right, we talked about this earlier about brushing your teeth. I did that on purpose, so you'll notice this is one of our artifacts. Toothbrush tachycardia. The next slide is from a man who's brushing his teeth. The arm movements jiggled the EKG wires and created what appears to be a dangerous rhythm. Okay? So that we all know that this cannot be good. That means this patient's heart is beating super fast. It's just going, ticking away like a bomb. This is called your toothbrush tachycardia. And you learned about tachycardia in chapter 7, I believe. A true lethal rhythm. The next slide is a true rhythm, and note its similarity. This is somebody who is actually having a ventricular tachycardia. Now remember, ventricular, we're talking about the ventricular chamber at the bottom of the heart. Your ventricles are down here, and your atrium is at the top. Ventricles are represented by your QRS, and notice, look at all of your QRSs, which means we're having a ventricular tachycardia. Very similar to your toothbrush tachycardia. We also have what's called your CPR, seen during CPR. Chest compressions can resemble ventricular rhythm. Whenever somebody is doing CPR, we're trying to get them back to breathing, but also we want to keep their heart pumping and their blood circulating so that they don't lose any kind of functions in the rest of their body. The chest compressions can resemble the ventricular rhythms, and it may cause the health care personnel to think that there's a rhythm when there is not. Here is your CPR artifact. So you can imagine pressing on somebody going up and down on their chest. This would be an artifact on the machine. The rhythm without a CPR artifact on the following slide is a rhythm when CPR was interrupted. The pattern resembles a rhythm abnormally wide QRS. Look closer. This is a rhythm without a CPR artifact. So this is somebody, they stopped CPR with the AED machine maybe, and it's trying to read an impulse, and it got one crazy looking QRS, which is representing my ventricles, which means my atrium is not getting a oxygen, and therefore this is a dying heart, and we need to continue CPR. Another artifact masquerading a rhythm is called your defibrillation cardioversion artifact. This is caused by sudden electrical surge entering the heart, produced when a patient is defibrillated or cardioverted. It causes the rhythm pattern to shoot down and up before the rhythm pattern resumes. As the electricity is dispersed, the true rhythm will then appear. So we have a crazy looking, so remember your CPR artifact looked like this. And a true CPR artifact looked like this. Okay, so here we're looking at defib and cardioversion. Here we're going to have what's kind of looking like a broken record. But notice it drops down and then it goes up. The artifact and 3 leads monitored simultaneous. Following is a strip with 3 leads recorded the same rhythm. Because the 3 are recorded simultaneously, meaning at the same time, all 3 are the same rhythm, just seen in different leads. V1 has less of an artifact and shows a true rhythm, whereas leads 1 and 2 are limb leads and show a lot of artifacts. So you'll notice this is V1, which is real. V2 and V1 are artifacts. So, is it real or is it an artifact? So, we notice that we see something different here. So, is this real or is it an artifact? How do you tell the difference? You're going to check the patient for symptoms. Remember, always check your patient for symptoms. See if the rhythm meets its normal criteria. Check another lead, preferably V1, which has less muscle artifact. Check if wire or patches are loose or detached. Observe for muscle twitches and movements, and follow the QRS complexes if any are